بسم الله الرحمن الرحيم. أقدم نفسي ليكم دكتورة ناهد محمد الصليح. أنا في قسم طب المسنين. موضوعنا النهاردة قسم طب المسنين، قسم الأمراض الباطنة، وموضوعنا النهاردة Falls and Fall Prevention in the Elderly بإذن الله. قبل ما ندخل في الموضوع, before we start in our topic, I wish to draw your attention to something, please. You will find by the end of this lecture, of this presentation, an appendix. It's a number of appendices in a number of slides, and these are meant, I'm going to show you these slides in a minute. Okay, so you can see that slide. These points that are written, they are 5 appendices, appendix 1, 2, 3, 4, 5. They contain, the text in there is contained. We are going to describe it, or we are going to explain it, inshallah, in our lecture, but it is not written in your books. The word form, which is in your books, this is not written there. This text, you will find it spread out in the PowerPoint. And these points written here are written in the PowerPoint itself. But it might be easier for you if you find it all in one place. And you can see here, it tells you page 166, that's in your book, under the title Post-Fall Syndrome. Please add the following to the description of subdivisions, and this is what you're going to write. If you go to Appendix 2, you will see Bismillah ar-Rahman ar-Rahim, page 172. Top line, it says, if there is a history of 1 or more falls, and between brackets, significant fall more than twice in 6 months, and then please add also or once but associated with injury. In the same page 172, under the heading of multifactorial assessment, the 3rd paragraph, and under that heading it says, if there is a history of 1 or more falls, significant fall more than twice in 6 months, and please add also or once but associated injury, and so on. These are 5 appendices you're going to find, and these appendices, actually the content, we are going to find it now through our work in the PowerPoint bi'Iznillah. So back to our topic from the beginning. All right, so what do you mean by falls? What is it? Any one of us may fall at any part of time, but the point is that this fall is non-syncopal falls. Non-syncopal, it means the patient is alert, he's fully conscious, he didn't lose conscious. The other point, that it is not caused by stroke, seizure, or overwhelming force. That's the fall we are talking about. And you can find here in the definition, the first 2 lines of the definitions, it says unintentional events in which a person comes to rest on the floor or ground. This is the definition of the word fall. It's a standard definition, we cannot exclude it. So it's just the word fall. But what we are concerned about, it is that these falls are not caused by loss of consciousness, and not due to stroke, not convulsions, that seizures, or overwhelming force. These falls are actually common. They occur commonly in elderly persons. Nearly a third of them, patients or persons above 60 or 65 years of age, they do fall at least once or twice a year. And these incidents increase steadily with age, and even it is more common in nursing facilities or hospitals. And because just you can imagine, if a patient or a person, old person, changed his environment, he's inside the hospital, and there are all this of stuff around him, medicines going and coming out, all this would make him lose a bit of consciousness of concentration, and it might go into a bit of confusion. So this would lead to falls. So the incidence is even higher in the hospitals and nursing facilities. So the point is, why would an elderly person lose balance? Any of us may lose balance at any part of his time. But in the elderly, there's something peculiar. First, it's a multifactorial etiology. It's not, if you come and examine your patient and evaluate, you will not find just a single cause for it. You won't find it like that. You find multiple causes. And we're going to give an example now. Say peripheral neuropathy together with ischemia, together with hypotension, together with weakness in his vision, visual acuity, multiple factors acting together leading to a fall, which means when we go for assessment for risk factors for falls in the elderly, if you find one risk factor, this is not good enough. You have to search for another and a third and a fourth, because the management, the more risk factors you manage, the better outcome you get. The other point is that falls can be prevented in the elderly. It was taken for granted till recently that falls is part of aging. It's not true. It was found that it is a preventable issue, and that's very important. But the difficulty to be really effective prevention is that you need multidiscipline. That's more than one specialty acting together, and that's the example we're going to mention here. A male patient, 70-year-old, he's type 2 diabetes, peripheral neuropathy, ischemic heart disease, osteoarthritis in his joints, diminished visual acuity, and some degree of dementia. All these in one person. He's generally, although he's got all these problems, he's generally functioning well. He's going here and there managing his life, but he had an attack of a fall. And these falls have repeated. We need to manage his fall problem. To manage his fall problem, you see how many specialties you need to work together. Geriatric medical doctor to control his medical conditions. You need an orthopedist for the advanced osteoarthritis in his lower limbs. You need ophthalmology for his vision, ENT for hearing, and neuropsychiatry for dementia. And above all, after all these people have done their role, you still need some physiotherapist, geriatric nurse, occupational therapist. These are the other specialties working together in one team to help the patient to train his muscles, to train his sensation. He's got peripheral neuropathy. He lost some of his nerves because there's degeneration of the nerves. There's muscle atrophy because of the neuropathy. You're not actually bringing back the muscles, you're not actually bringing back the nerves. But this physiotherapy and these people help him to make use of what he's got left, whatever residual muscle functioning is left, or whatever residual sensation is left. They do training programs to help him to improve his functioning capacity of his muscles and sensation and so on. So you see, that's why I say it's multidiscipline, and such big team of specialties to work together are present in specialized fall centers, but unfortunately there are few centers worldwide. There are just very few, and that's why prevention of falls is still a community-wide problem. We don't have the sense that falls are now really preventable. They are, and these centers do come to proper or good outcome of preventing or reducing falls, but they are very few around the world. So why are we concerned about falls in the elderly then? Okay, because of the complications. If a person, old age person, drops to the ground, first thing is we fear of is fractures. And fractures, the most dreaded one is hip fracture, because after a hip fracture, the patient is kept in bed for a long period, and he may go into complications of that. And the other point is complications of hip fracture, and these complications may cause mortality. 20% die within a year of a fracture, and half of them, if they are living and they pass it alive and they are okay, half of those who have lived it, the no mortality occurred, half of them are not able to live independently after that. They still need assistance, and probably they are not sent home. They live in long-term facilities. Soft tissue injuries, head trauma, lacerations, these are fall injuries, are very serious. But the most common ones are other consequences. These are other complications of falling. That's fear of falling, loss of independence, long lie, and placing the elderly in a nursing home facility. What's fear of falling? We're going to discuss it now, but to give it in short, that the patient gets scared. If he had a fall like that lady and she stayed on the ground for a while, they get scared that he may stumble. So it hinders his daily activities. He stays in his bed, he stays in his chair all day long. He doesn't want to go anywhere, he doesn't want to move around, just because he's afraid he may lose balance once more. And that will put us into another complication, which is immobility. And that's the main issue. We're going to manage and see how immobility would cause lots of complications to our elderly. Loss of independence, he needs the help of some other person, which is a very bad outcome for the elderly. One of the main aims of geriatric medicine is to keep elderly persons independent of other human support, of other human service as much as possible. So if you lose that, you're losing a lot. Long lie, that's staying on the ground for more than an hour and has serious complications. We're going to discuss it now. What's long lie? This lady, after she fell on the ground, she had a long lie on the ground. That's remaining on the ground more than 1 hour after a fall. And this may happen if, say, her son or her daughter are at work, and when they come back, they find her there. When she has a fall, she's too weak to get up from the ground. The muscles are weak, and as she's lying there, she's losing temperature. Her body heat is being lost to the ground, and her own thermoregulation, generation of heat, is diminished. It is normally diminished by aging. So there is no good compensation. They go into hypothermia, and dehydration, pneumonia, all these are complications of this lying down process, and what we call rhabdomyolysis. What's rhabdomyolysis? Myo, these are skeletal muscle fibers. Rhabdo, these are striated. So myo, this is muscle fibers. Rhabdo, these are skeletal. So it is striated muscle fibers or skeletal muscle fibers. They go into lysis. And lysis, this is as if it's dissolution, as if they dissolve. They break down. And especially at pressure points. So that lady, she's been there at her shoulder, at her elbow, at her trochanter, at the side of the leg, the pressure points where she's been lying. Muscles at these areas will break down. And this breakdown starts 1 hour after lying like that. And so what's the danger of this? It's going to release the content of the muscle fiber. And the contents, lots of contents will be released, but what we are concerned about our clinical session is the potassium, myoglobin, creatine kinase. Creatine kinase is an enzyme in the muscle fibers. It's an indicator for me as a clinician. When I take a blood test, if I find it raised, it helps me to say that rhabdomyolysis is going on. Myoglobin is like hemoglobin in structure, and it goes into the circulation, and as it is filtered through the renal tubules, it blocks the tubules, and the patient will go into acute kidney injury. Potassium will go into hyperkalemia, which causes fatal arrhythmias, hyperkalemia. So these are very dangerous outcome of rhabdomyolysis. And how are we going to identify it? First, it is you have to consider the situation. An old person that has come to you by himself or his relative, his daughter or her son, brought his parent to tell you that he had had a fall. I found him falling on the ground at home. You want to check for anything that happened or what complications might have happened. First, you have to check how long has he been on the ground. And if you are not certain, this point, if any person, you are not certain how long he's been on the ground, from the history of the relative, of the patient, how long he's been, then consider it's been long lie, to be on the safe side and act accordingly. In other ways, evaluate for a long lie. What are you going to do? You can have a blood test to measure serum potassium, to measure creatine kinase, to measure kidney functions, that's the blood urea creatinine, and urine, urine output, you collect the urine for urine output, and you do a test, a dipstick test in the urine analysis. What's the use of the dipstick test? A dipstick test would give a false positive myoglobin. It gives a positive for hemoglobin. And I mean false positive for hemoglobin. I mean the dipstick will give you a positive for hemoglobin. But you know clinically that this patient has been lying on the ground for more than an hour, then this hemoglobin, you should expect actually it is myoglobin. You can test the urine and send a lab sample to analyze for myoglobin, but this is going to take several hours until you have a result. And you cannot wait these several hours, you have to act very fast. So what you do is clinical situation, the patient has been on the ground for more than an hour or an uncertain period, so consider it more than an hour, and you have a dipstick test in the urine positive for hemoglobin. Then consider it's myoglobinuria and start management. That's give him IV fluids. You have to start very early. We give a lot of IV fluids aiming at making a gush of fluids through the renal tubules to avoid blockage of the tubules to prevent acute kidney injury. So you have to start early to be able to prevent it. But take care, caution, take care that the patient may have heart failure or hypervolemic state of whatever reason, and this would be a contraindication for fluid. So we are in a hurry to give fluid, but before giving it, we have to be cautious. Can we give it or not? That's one point for myoglobinuria, and the other one for hyperkalemia. When you have a blood test and you find hyperkalemia and arrhythmias, you give insulin dextrose infusion, calcium gluconate, proper rehydration to correct the hyperkalemia. But hypocalcemia, we do not correct it. You do not give calcium unless it is severe hypocalcemia or the patient went into seizures from a severe hypocalcemia. Otherwise, don't give it, because if you leave it for a while, if it is mild hypocalcemia, it will correct itself by its own. And if you have given your own calcium, you put him into a hypercalcemic state. So we don't give calcium replacement unless there is severe hypocalcemia. Okay, the other complication is hypothermia. Hypothermia, this is the core body temperature goes below 35. This is mild. If it is below 35 down to 32, this is mild. If it is below 32 down to 28, this is moderate. If it is below 28, this is severe. And the mild form, the patient is fully conscious, he's alert, he's shivering. Shivering is a good sign. It tells you it's mild. And there should be no arrhythmia. You should feel his pulse and you should find no bradycardia. So he should be alert, no bradycardia, and shivering. The other point, when you use your thermometer, the ones that we use in our clinical ward, our thermometer, the lowest reading is 35. So how am I going to identify hypothermia? As we mentioned, the clinical situation, long lie after a fall, and the thermometer that does not go above 35. Why do not measure the core temperature? Core body temperature actually needs special probes that are not available in our clinical wards. These special probes are present in most, maybe should be in all, I'm not sure is it in all or in most of intensive care units. So what are you going to do? As we mentioned, clinical situation, and your thermometer is not going above 35, and the patient is fully alert. This is to understand, and maybe shivering. This is mild, but if it is moderate, the patient goes apathetic. What's apathy? It looks like that. Slow, not reacting, as if he's not focusing, not concentrating, and he's not shivering. Because when he goes to moderate, the muscles are too weak to shiver. They can't shiver. So the patient will be coming to you, there's no shivering, but you don't feel that he's fully alert. You don't feel he's concentrating with you properly. Okay, so you have to consider hypothermia, and you have to notify intensive care unit to come and measure and do what they can about it. And if you have a mild hypothermia, what you do for the patient in the meantime. What you can do is keep him dry. That's his clothes should be dry, not wet. Then whatever he's lying down should not be wet, and keep him warm. Warm clothing, a warming blanket, hot drinks. All this is really important, and it can compensate the mild form. Moderate and severe, they need an ICU, intensive care admission. The other complication that we're talking about is post-fall syndrome. What is that? Post-fall syndrome, we've mentioned before, this is fear of falling. We're going to mention it now. What is this? That man, Bismillah ar-Rahman ar-Rahim, he was actually probably having the diseases we mentioned before, probably diabetic, probably hypertensive, osteoarthritis, but actually he was managing his life quite okay. He was functioning, moving around normally. But he had a fall. And after that fall, when he gets up, he gets into great fear of falling. It's a severe anxiety reaction, very peculiar reaction in the elderly. And when he starts to erect, you see what he's doing? He's trying to catch the bed. He's not standing steadily, so irregular, trying to catch everything around him, try to grab, as if he's panicking. This is what they call a post-fall syndrome. And it is considered severe if this reaction is so severe to the extent the man will not be able to walk on his own again. He needs another human being. The point is another human support. Okay? If he's going to, the moderate type will walk again. He will have the same reaction. He will walk again by encouragement and by soothing and some psychotherapy. Even with using a walking cane, it's okay. Using a walking cane is okay, because it means he doesn't need another human support. That's the point. So in the severe form, he needs another human support, and when he gets that support, he walks normally. So this is the post-fall syndrome, and it's in condition that he has no neurological deficit, no fractures, no physical disability that's happened out of the fall. So why is he not moving around? That's the severe form. The moderate, as we said, he will, but after some encouragement, even if he's using walking cane, so long as he's not needing another person. And absent syndrome, it means that after the fall, he managed well, there's no problem, he didn't even go into this anxiety reaction, and he may still use a walking aid so long as doesn't need another person. So why did it happen? It was given the name, this post-fall syndrome was given the name phobia. And phobia, this is a phobic reaction. It's a severe reaction to standing or walking after the patient had a fall. And it was thought it was a severe anxiety reaction because of the fall of the patient. But studies have shown that it does occur, this fear of falling, this severe reaction does happen in some elderly person who have not fallen before. And this was really weird. How come? They never had a fall before. How come they go into this fear? And the term fear of falling is now the term used. So it's no longer called post-fall syndrome or phobia. It's fear of falling to encompass those who have fallen and those who did not fall, fallers and non-fallers. And this fear of falling, when do we consider it a problem? It's when an elderly person is so much concerned about that his balance as he goes around, that he's so much afraid he might stumble at any time, that it hinders, it limits his daily activities. He just lies there and he doesn't do anything. Once it did reach that level, then it is really serious, because it would put him into complications of immobility. And here you can see the fear of falling syndrome. As we said, it's not only a post-fall reaction, it is not normal for aging. It's due to a decline of physical health. That's because these people have multiple diseases and there's a decline of physical health. And what's the difference? If you say normal for aging, so what you can do about it? You don't expect you can do anything about it. But if you say it's a physical health problem, then it is something that you can manage, something you can treat, something you can prevent. And this is true. Research has proven that it is due to decline of health. It's not normal for aging. It is associated, this fear is associated with anxiety and depression, but this is not the only reason. It's also associated with sedentary lifestyle, and it's a more serious problem than falling itself. Why? Because it will put the patient into immobility, and these are the complications of immobility. You see, it's a downhill spiral if the patient sits having a bed rest day and night every day. He doesn't go around, he goes into a downhill spiral. That's a decline of every single system in his body until a fatal outcome. It's real suffering of a preventable issue. Skin goes into pressure ulcers, muscles atrophy. Muscle starts to atrophy one day after complete bed rest. And every day he loses 1 to 3% of his muscle fibers daily. Bones, bone resorption. Minerals seem to dissolve out of the bone, and he goes into osteoporosis. Joints stiffen, and this is very miserable. The joints are actually normal. There's no disease, but the soft tissues around, muscles and ligaments around, because of immobility, they get stiff, and he gets into a vicious circle. More difficult to get up, more stiff. And if he spends several months like that, this stiffening turns into contractures. They turn into fibrous tissue, and the patient, you find him in bed doing like that. This is flexed, this is flexed, this is flexed, this is adducted and flexed. All his body, due to flexures here all around, he gets fibrous tissue. So this is really a miserable outcome, which is really preventable. Cardiovascular system, decreased cardiac output, hypotension, pulmonary pneumonia, constipation, UTI, decreased basal metabolic rate. Every single system is affected. So this is the real big problem. So to sum up, complications we mentioned till now is fall injuries, fear of falling, again, that's encompassing post-fall syndrome and what mentioned now, fear of falling, the problem of immobility, loss of independence, long life, and we discussed rhabdomyolysis and discussed hypothermia, and placing in nursing home facilities. So what we can do about it? We said this big problem, we call it a geriatric giant, could be prevented in specialized centers. But what about our community? What can we do about our community? There are points that we can help our elderly patients with to minimize the rates of falling, to minimize the impact of the fall. If he falls down, he doesn't get hurt. So we're going to mention these now, inshallah, hoping to be of benefit for our elderly subjects. Risk factors for falling. You ask your patient by history. When you go for screening for risk factors, you ask your patient by history. Age, the older he is, and age over 80 is very risky. Use of assistive devices, previous falls. If he has fallen before, he's liable to fall again. And the circumstances, you should ask about the circumstances of the fall. Was it during daytime, nighttime? Was it during the bathroom? Micturition syncope. The patient, as he micturates, in the elderly, some elderly person have exaggerated vagal reflex. So as he stands to micturate, the vagus gets stimulated excessively and goes into bradycardia, hypotension, and if it is severe, it's syncope. If it is mild, he loses balance. If he's got a hypersensitive carotid sinus here, each time he turns that way, it stimulates the sinus, and the baroreceptors here, when they are stimulated, they cause bradycardia, hypotension, which is very serious. When he crosses the road looking this way, that way, each time he looks that way, he's at risk of falling. So these are situations which repeat themselves. So if you ask about them, we can help to tell you what possible risk factors are there. Vision and hearing. Hearing, please, is a real risk factor. Hearing, not only vestibular function, this is inner ear function. Yes, it is known that it will cause loss of balance, but hardness of hearing. Elderly don't get these hearing stimuli when I talk to them or you talk to me. You're talking together. Your voice, what you're going to tell the man or the person, when he gets inside, you've got degeneration in the receptors, you've got the synaptic connections, changes in the synaptic connections, you've got changes in the neurotransmitter. So the outcome of all this process with aging is that he doesn't realize properly what's going on. He may hear something, but he might not understand what's that, and that will draw his attention, and that they make a lot of effort to focus or to concentrate on his footsteps, and that would give him a real risk for falling. So it's a routine place in screening for elderly for falling risk factors. We check for hearing. We need an ENT specialist to check for hearing. Vision also, goes without saying, visual acuity, but please also multifocal lenses. That lens I'm using is a multifocal one. When I look distant, I'm using that. When I'm reading, I'm using this. So what? When I'm standing, I'm looking on the floor, watching my footsteps as I walk, I'm using that. These lenses are meant for reading. They do not give depth perception. So the patient will look down, trying to take care of, watch his footsteps, but actually he loses depth perception and he stumbles. So in old persons, we no longer use multifocal lenses. It's much safer to use two types of glasses. One glass for long distance and another one for reading. Dementia, depression, postural hypotension, postprandial hypotension, musculoskeletal impairments. You do not need to find real abnormality in the lower limbs to say that this is going to cause him to fall. You may even, yes, they do cause him to fall, but I mean mild changes, just calluses, bunions, long toenails. The toenail may be very long, that it hinders his walking, or an abnormality in the joint, or just ill-fitting shoes. It seems probably to us, it's too mild to consider. For an old person, it is really serious. And we also check other systems. That's examination, chest, heart, abdomen, CNS, nervous system, for tremors, for peripheral neuropathy, and the like. And then you move on to checking his medication list. Medication list two items. You ask your patient to bring with him the bag from his home, and you do two things: the type of the drug and the number of the drug. The type of the drug, some medicines give a side effect that lead to fall. They cause some confusion, they cause some dizziness, so you need to change the type of drug. And these are examples: anticonvulsants, sedative antihypnotics, antiarrhythmics. These are type. But what we need to notice is also the number. Prescription and non-prescription drugs, that's the over-the-counter drugs. You need whatever number of drugs he's taking daily. If he takes regularly on a daily basis 4 or more medicines, which is very common in old age, they all have, most of old elderly patients have multiple disease, so they take more than 4 drugs a day. The more they are, the higher risk. And my job is to try to cut down the number of medicines he's taking. And I should count also vitamins, medicinal herbs, whatever medicinal thing he's taking, whether it be prescription or non-prescription, should be counted. And it tells us here, please, if the patient is used to 12 medicines a day, and you will find that you come across elderly patients taking 12 and 15 types, it's really it's not logic, but we do encounter that a lot. And if you do diminish the 12 down to 6, so you are actually diminishing risk of falling 50%. So it's really efficient to try to diminish the drug number. And then the last point here in the history taken with the patient is a recent hospital discharge on acute illness, because the first 2 weeks after he goes out of hospital, his risk of falling increases. This because, why was he admitted? Because of acute illness, pneumonia, heart failure, chest infection, chest pain, urinary tract infection. The acute illness itself would raise the possibility for falling or losing balance, and the change of environment in the hospital, the medicines, the change of medicine, the change of people, all this, when he goes back home, he's very high risk in the first 2 weeks of coming out of hospital, of discharge. So just go to sum up what risk factors you mentioned: age, assistive device, previous falls, vision and hearing, dementia, depression, postural hypotension, postprandial hypotension, musculoskeletal, other systems, chest, heart, abdomen, and so on, medicines number and type, and recent history of hospital discharge or acute illness. Environmental hazards, just to give you an example, environmental hazards are mentioned just to give you an idea. It's a special profession. Occupational therapists are concerned with that, to care for the environment of the patient. In our place here in Alexandria, we've got the geriatric nurse, the College of Nursing. They have a special department for geriatric nursing, and part of the job is for this environmental part. You can see here this environment, you can see this ladder, this staircase. It's monotonous. With the diminished depth of perception in the elderly, he can stumble easily. But what about that staircase? It's made of two bright contrast colors, and up there on either side, if you can see, up there, you've got two grab bars, because he should support both hands as he goes up and down. That's a better staircase than the other one. Okay, here slipping mats, here trailing flexes. These are examples. So what to do for screening for falls? First, when we do screening for falls, we ask about the risk factors we mentioned before. That's just a history, and the clinical examination actually should have been done in the medical part of examination of this person. When you go and examine him medically, you examine his pulse, his blood pressure, general look, and then you go chest, heart, abdomen. So the medical part actually has been done, and you are left with the history taking for the risk factors, and then you ask at least once a year if they had fallen before, and you do a test. We call it timed get up and go test. We're going to mention it now. Screening by checking vision and hearing, reducing medications as we mentioned, manage and treat osteoporosis. Just in case he does have a fall, then he doesn't get a fracture. Exercise and home safety, we're going to discuss it now, inshallah. What's time get up and go test? It's a simple clinical test that we do in our office, and it is designed, it's an international test. It is made for non-geriatricians to take less than a minute to be done. You ask the patient to sit on a chair, and this chair should be firm or hard and sturdy. This chair here in the photo, it is hard, but it's not sturdy. Sturdy chair is something, I don't know if you can see, the one I'm sitting on should be stable on the ground, not on wheelchairs, not on wheels. It has to be stable, something like this, steady furniture, because the patient, when he stands up, he needs the chair to be stable. So this chair is hard, it's not sturdy. All right, and you use a measuring tape, and you measure starting point, and the end point is 3 meters away, and this is a standard distance, 3 meters, and you use your measuring tape 3 meters away, and you ask the patient to sit. You tell him, when I say go, you start your stopwatch, you say go, the patient stands up, walks this point, and then turns back, comes to sit. And once he touches, this bottom touches the chair, stopwatch, and see how much time did it take him to do this journey. You try this test twice. First time for the patient to get used to it, and then the second time we really count the time. And the patient should walk with his normal walking pace. We need to know his walking speed, his normal walking speed. He doesn't need to hurry. He shouldn't hurry. Okay? And if he takes 14 seconds or more, this is increased risk. Why is it increased risk? Even if he's doing it so nicely and so well balanced, and he came back, but he made the journey in 14 seconds, that's too long. Why? Normally in adults it takes 9 to 12 seconds. And if he takes 14 or more, this means he takes too long to keep his balance. So if anything he needs to hurry for any reason, he's going to lose his balance. Okay, so what we're going to do, we said, you asked for risk factors, there's no history of falls, you test his balance, mobility, or gait. This is, you ask your patient to walk around, and you should expose his lower limbs, to watch him walking, but please be available yourself or your assistant, because he may lose balance, so I should support him if he's going to fall. Okay, so you test that and you find no problem with balance, mobility or gait, a normal time get up and go test, then reassess after a year. That's it. There's no specific lab test, no specific investigation for falls. The investigations you're going to do are according to his medical condition. This is to evaluate his medical condition. All right, then reassess after a year. Otherwise, if you find an abnormality, then you need a more in-depth. What abnormality you may find? Significant fall, as we mentioned. If you find in the history, he did fall more than twice in the last 6 months, or he had a single fall, but it was associated with an injury, that's a significant fall that this person should be referred to a specialized center. Or there's an abnormality in the timed up and go test, or any abnormality with mobility or gait. These are selected cases. These are the cases that you are going to select to send for specialty care. And at the specialty care, this is the specialized centers that we should have. They should do multifactorial assessment. That is a more comprehensive, more in-depth evaluation. And the patient actually lives in these specialty care centers, specialized centers, probably a couple of months, because they do construct special training programs to cover all the items as we mentioned before, and he is actually trained to live in a certain situation by a certain means so as to keep him from falling. But as we said, if we don't have, and then at the end of the story, after these couple of months, this person is discharged home with a full plan of how to manage at home. This is the ideal how it goes, where you have got a specialized center. But where you don't have a specialized center, what are we going to do? There's some issues that we can do that help our elderly patient in our community. Although they are not ideal, they are not, as academically as we mentioned now, as a specialized center, but they still can help a lot. So these are effective interventions to reduce falls. Exercise, teach him how to get up from the floor, de-prescribing, safety in the home, diminish the impact of a fall, and medical alert. We're going to discuss these, but we wish to mention here, please, de-prescribing strategy. What we mentioned before, if a patient is used to 12 drugs a day, you do not, for several years, he's been like that. You do not come today and cut them down to 6 abruptly. We do not do that. We go down stepwise, and it has a specialized strategy where you follow, and we call it de-prescribing strategy, which is a gradual withdrawal and change, modification of the drug prescription to reach the optimum minimizing we can do. For the exercise, you need at least minimum 10 weeks. That's 2.5 months of individualized exercise. And what do we mean by individualized? Remember we said I need a physiotherapist. Why? He's the one going to put the plan of an individualized plan of exercises for that person. And we give an example. If patient is losing balance because he's got a hemiplegic side, there's weakness in an arm and a leg, different from a person losing balance because he's got a peripheral neuropathy, different from a person losing balance because he's got an osteoarthritis. So at the end of the day, what's the most suitable exercise program for that specific person? That's a plan done by a physiotherapist. And if it is properly done, in 10 weeks, that's 2.5 months, you can really get improvement of red muscle fibers and improvement of gait and balance. Tai Chi exercises are group exercises. They are very good for the general well-being of the elderly, but not specific for the fall. But they are very good for the general well-being. Also moderate intensity walking, 30 minutes a day for 5 times a week. Moderate, not brisk walking. Brisk walking, they're going to fall. These are good for the general well-being, but what we are aiming at, individualization of exercise. The other point, how to teach our patient how to get up from a fall. That's an example. A lady fell on her back, and then she's being trained by a physiotherapist how to roll onto her on her arms and knees, and then to crawl to a sturdy chair, a steady piece of furniture, and get support and sit on it. And in our clinical session, hopefully, inshallah, we're going to discuss this. We're going to do it together, hopefully, bismillah. For the home environment, you need a geriatric nurse that's in our community. Abroad is an occupational therapist, and they go and visit the homes of the elderly, and that's an example. This staircase, 2 grab bars on either side. This bathroom, this one. The bathtub, this chair is fixed on the ground. The foot place where he steps on his feet, they have non-skid mats. These are rubber mats, which is not slippery. Fix it on the ground, and he's got grab bars here to help him. And see this toilet seat? There's another device put on it to make it the proper height, and arm stands for him to support, and grab bar, and so on. These are just examples for us. It's not our job. We cannot imagine how far. That's a checklist. And this checklist is an image, a bedroom, kitchen, a bathroom, living room, and under each title it tells you, and these are other rooms in the house, and under each title it tells you what you should do to minimize the risk. This is a whole profession of geriatric nurse in our community, of occupational therapists in other communities. Diminish the impact of the fall is to say that, just an example, also that's the job of a physiotherapist, of a walking cane. A patient using a walking cane, when he loses balance, he holds tight to his walking cane. The walking cane hurts him when he falls down. So he's being taught that if he feels he's going to lose balance, to do external rotation, to do like this. Throw the walking cane away and let himself fall. This would be much safer for him. Parkinsonian, this lady or man, whoever patient has got Parkinsonism, with a retropulsion. When he steps back, this is not propulsion, this is retropulsion. When he steps back, he loses balance. So he's taught, if he steps back, to do squatting. If he feels he's going to lose balance, to do squatting. So this squatting will let him sit on the floor rather than falling. This will mean the diminishing of the impact of the fall. We did not stop the fall, but we made it not hurt him. This is the job of, we said, a physiotherapist, so it's just an example. What's a medical alert system? 911 system is something like that. An elderly wears a pendant or a bracelet with a button. If he falls at any time, he just presses the button. It contacts a specialized center. They can talk to him, and they can send to him someone to help. And it might have also a GPS tracking if he's outside the home. Other assistive devices, these are hip protectors. Actually, recently they're not being used. The idea was that it's a shock absorber. It's something that they wear below their undergarments to, if he does fall, to prevent, it's a shock absorber, to prevent hip fracture. That was the idea, but it's very cumbersome to use. So it's no longer. Actually, this Zimmer frame, it has wheels. Some Zimmer frames don't have wheels. Some of them are tripod, and the choice also is the job of the physiotherapist, which is the best Zimmer frame for that person to use. Effective interventions, not effective in reducing falls. We mean by these, why are we mentioning these? It's because they have been being used. They are people used to describe vitamin D supplements for every old person. They think, especially those who are falling, and they think that if I give him vitamin D, I will improve the condition. No, please don't. If he doesn't have a vitamin D deficiency, do not give vitamin D supplements. Please. If you give it, you will give him, first, you're increasing the number of medicines he's taking, and this will increase the risk for falls. Second, he will go into toxicity of overdose of vitamin D. So you have to check first vitamin D. If there's deficiency, correct it. No deficiency, then there's no need for it. Don't use it. Education. Education is just what I'm doing now. Sitting on my desk, telling you what to do and not what to do. This is education. It's no longer done for an elderly. It's a training program, as we mentioned, and you need the help of a geriatric nurse, a physiotherapist, special centers, where he lives there for a long period, till he gets trained to whatever you want him to get used to. Routine comprehensive multifactorial assessment, as we said, is no longer routine. multifactorial assessment is now done for selected cases. These cases are for primary care physician. This is you, inshallah, when you're done with your studies. You select by screening methods we mentioned. Who should you should refer to more specialized evaluation. These are patients that we said who have significant falls or abnormality with gait or an abnormal time get up and go test. So what we mentioned till now, effective interventions to reduce falls, that's exercise, how to get up from the exercise, that's a physiotherapist. How to get up from the floor, this is a physiotherapist. Prescribing, this is a medical doctor, together with controlling his medical condition. Home safety, this is geriatric nurse. Diminish the impact of the fall, this is a physical rehabilitation therapist. And now comes how to use the walking canes correctly, please. You can help your elderly with just teaching them how to use it. Proper height, you can see the height of that walking cane. The handle is at the level of his greater trochanter. That's the proper height, at the level of his greater trochanter. If it is too high, it's going to do like that, and the shoulder will go into osteoarthrosis, which is more disabling. If it is too low, it's going to do like that, and he will lose balance. So the proper height is handle at level of trochanter. The second, he should hold it opposite the disease side. If this man has got a disease in his left leg, then he should use the cane catch the cane on his right side, and vice versa. Going up or downstairs, it doesn't make a difference which side the walking cane is. Why? Because both hands must be supported. One hand catching the grab bar on the staircase, and the other hand catching the walking cane. Both hands must be supported, and then he goes up with the good leg first. If he's going down, then he goes down with the bad leg first, or the sick leg first, and both hands must be supported on the staircase. That's the main issue. So by now, I hope we can notice that our aim of screening, selecting, sending to specialized centers. We don't have a specialized center in our community. We can do some effective portions, as we mentioned, exercise these points that we mentioned, and these are available. And the team here, physiotherapist, medical doctor, geriatric nurse, physiotherapist, that's the minimum geriatric team we need to work together. A medical doctor, geriatric nurse, and geriatric physiotherapy, and these three personnel are available in our community. So we should work together as a team, and we can do a lot for our elderly by these three persons. And the main aim is patients who are always get falls, keep him moving, please. Do not prohibit moving. No, we keep him moving, but in a safer situation, because if we prohibit moving, we actually prohibit only the hazardous situation, really hazardous situation. Otherwise, we do not prohibit moving. We try to train him to move safely, to avoid immobility. As we mentioned, it's really fatal. Immobility is a lot of suffering till death. So I hope by now you can do something, or I hope that you could reach something we can do for our elderly persons. Till here we come to a close. I hope it's been of benefit, and shall I say thank you very much.